Next, Dr. Aswathy. Okay.
Tips to tackle traumatic subluxated lens. This is a case of 42-year-old male with defective vision right eye following blunt trauma. On examination, infratemporal zonulodialysis of 4 clock hours and cataract noted. We plan for phacoemulsification with capsulotension ring with intraocular lens implantation under guarded visual prognosis. We can see an FAK crescent on retroillumination. Side port is created. Under air bubble injection, trypan blue staining is done and washed. Viscoelastic is injected. It is advisable to use cohesive high molecular weight viscoelastics as it acts as a tamponade and prevents the prolapse of the vitreous through the area of the zonulodialysis. By using 2.8 mm keratome, a clear corneal incision is made. Capsulorhexis is one of the most difficult part in such cases due to lack of resistance from the zonules. Start the capsulorhexis away from the subluxated area to avoid the zonular stress. We can see the difficulty in making a rhexis, the difficulty in taking the flap and dragging the flap. Aim for slightly smaller rhexis in case we want to do an optic capture. A gentle hydrodissection is done to separate the epinucleus. Avoid the nuclear rotation, which further weakens the zonules. Phacoemulsification is done in stop and chop technique. Phacotrunch is initiated to get a linear groove, and after reaching the adequate depth, the nucleus is split into 2 heminuclei using the phaco probe and the dialer. Now we notice the prolapse of the vitreous into the anterior chamber and peaking of the pupil. So phacoemulsification is stopped and a 23 gauge trocar is inserted 3 mm away from the limbus. Tricot is used to stain the vitreous into the anterior chamber and anteriorly prolapsed vitreous is cut with the vitrector. Now we can go again in phaco 2 mode, bringing the nuclear fragment into the pupillary plane and emulsify. Here the phaco is done with low parameters, which prevents the raised intraocular pressure and less zonular stress and dialysis. Bimanual irrigation and aspiration is done starting from the side opposite to the area of the zonulodialysis. You can see the thick epinuclear plate which is removed and aspirated in the anterior chamber. Now using the irrigation in the anterior chamber, limited pars plana vitrectomy is performed to prevent any further prolapse of the vitreous. The capsular tension ring is inserted to expand the bag and to provide more stability. In this case, we are using the bimanual method in which the forceps guides the leading part of the capsular tension ring directly into the area of the subluxation and the trailing part is threaded into the bag with the help of the dialer. The CTR is dialed into the bag such that the weak zone is adequately supported by the ring. A single piece foldable IOL is injected into the bag and trailing haptic is gently pushed under the anterior capsular margin so that the haptics are placed in the areas of the ZT. Now you can see the well-centered IOL in the back with round pupil. Trocars are removed. AC is formed with air bubble. We can see the pre-op eye with infratemporal zonulodialysis and cataract with best corrected visual acuity of 3/60. Also, the 6-month post-op eye with clear cornea, round pupil and well-centered IOL with best corrected visual acuity of 6/9. So, the take-home messages are: make sure we have the options for secondary IOL before the start of the surgery. Use high molecular weight cohesive viscoelastics. Capsular access should be initiated away from the area of zonulodialysis. Gentle hydrodissection should be done with no nuclear rotation. Phacoemulsification should be done with low parameters. CTR should be used to stabilize the bag. If vitreous is present in the AC, anterior vitrectomy should be done after staining with triamcinolone.
Though you said the rexus should be started away from the dialysis, you started there only. And then almost 180 degree, nearing 180 degree of dialysis. So I think CTS must be a better choice, no?
4 to 5 clockers, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am.
Okay.
The only thing you'll have to look for decentration.
Yes, ma'am. That's why 6-month post-op, it was well centered.
Thank you.